And so that's why I came up with this particular topic. Dr. Thomas Scalea, who is truly a household name, physician-in-chief of Shock Trauma Center, arguably one of the premier shock trauma centers in the world. He's obviously professor of surgery. He's a Kelly, Francis X. Kelly, professor of surgery at University of Maryland, has done so much to contribute to the literature. We all owe him a great debt. Will be taken to pro. The con will be taken by Dr. Efron, who we also know. He is the chief of the division of acute care surgery, associate professor at Hopkins, and so the pro will be taken by Dr. Scalea. Dr. Scalea.
Thanks, LD. Which, that's forward. Well, it's a pleasure to be back again, and I have to say it was a few weeks ago that Dr. Efron invited me over to view the new palace at Hopkins, and thought that was awfully neighborly of him. I went and visited, and he said, you know, we should go get some pictures up on the roof. So we went and shot pictures, and he sent them over to me. And I began to realize that this was a cheap attempt at physical intimidation. David, it's not going to work. Now, on first blush, autotransfusion must be good. It's nice warm blood, there's no risk, it supports all the principles of trauma resuscitation, intravascular volume to support cardiac output, red cells, coagulation factors, it's warm, and it all goes to support aerobic metabolism with the attempt to clear lactate to normal. That makes some sense. And it's been a bunch of years. This was one of the early reports that not only supported the use of autotransfusion, but autotransfusion in people with GI injuries. This was Greg Timberlake and Norm McSwain. It's, you know, a bunch of years ago now. And it really was sort of a revolutionary concept. Now, I was interested. I went back and looked at the microflora. It must be a little different in New Orleans than it is in the rest of the world, because I don't think we get a lot of Staph epi, Staph aureus, or streptococcus out of the colon in people in Baltimore. Perhaps things are a little different in New Orleans. And I'm here to tell you that I'm not so sure that autotransfusion is so good. The idea that cell-saver blood is the same as the patient's blood is in fact not correct. Banked blood doesn't have to be cold. The risk of banked blood has largely gone away. And newer transfusion strategies may be as good or better than autotransfusion, and this all may be no longer a point that really requires discussion. Now, the situation is that banked blood is now very, very safe. This is 2012 NIH data that says that the risk of HIV, hepatitis C, and human T-cell lymphotropic virus is about 1 in a million donations. The risk of hepatitis B is about 1 in 300,000. There were 8,000 HIV infections in blood in 81 to 85, but only 49 since 1985, and 3 in the United States in the last decade. Blood is safe. And in fact, most people are immunized against hepatitis B, making banked blood a very, very, very safe alternative. Now, how about taking the blood out of the patient, put it in the wound, sucking it up, and giving it back to the patient? Well, it turns out that's maybe not such a good idea, and this was some of the early data looking at just doing that without washing the cells. There were an awful lot of problems. They said, fine, the solution is to wash the cells.
Thanks very much. Just a disclosure, we actually don't do autotransfusion at my shop, but I have to tell you that, well, we don't do it routinely. I will tell you that doing this debate has actually given me a little bit of pause. I too have the same picture. In case anybody's wondering, I'm the one on the right. And I've seen this picture before, and I know you've seen this picture before. And it took me a while to figure it out, but then it actually came to me. And again, I'm the one on the right. And in case you haven't noticed, the part of the movie, it says, only their mother can tell them apart. So if you're not nice to me, I'm going to tell Mom on you. Obviously, the problem is well described as blood loss, and that's what we go after, and that's what we do. And our objective when we have this is to correct the primary insult, that is, stop the bleeding, by also minimizing secondary insult. So how we actually do that, how rapidly we go after the hemostasis, but also, we've adopted balanced transfusion strategies. And I do submit that perhaps autotransfusion may have a role in these strategies. Basically, there's really two components to this. There's a very simple autotransfusion that we actually talk about that a lot of you may actually use, and that's the chest drainage. We didn't really hear a whole lot about that. And then there's the more sophisticated cell saver technology. Well, as Tom said, why are we even talking about this? This is a schema of our massive transfusion protocol. It was well thought out. It took us about 2 years to move the pillars of heaven where I am to get this taken care of, and actually it does. It's actually one of the most enthusiastically embraced system. In fact, we proposed it for trauma, and the medical board told us that it had to be available to all massive transfusion instances in the hospital, and that's terrific, but the reality is it only gets applied in a very small percentage of patients. Less than 10% if you actually, well, certainly less than 10% overall, but even in trauma in a busy center, about 14% of the time would you actually have patients get greater than 10 units in 24 hours. We're not talking about the ones exsanguinating in front of you, we're talking in 24 hours. Is there a cost? Well, we all know that if you predict wrong, you could say, okay, we'll just start the massive transfusion protocol and start our balanced resuscitation, but they actually may not need it. And if you do that, there is a cost. So for patients who get less than 10 in 24 hours, the plasma transfusion is associated with actually significant costs, such as ARDS, multiple organ failure, and this is not inconsequential. Patients may actually not need that. The easy version, the autotransfusion, you see that there are multiple commercially available systems that do that, to use this. They look something like this. They're most easily used in chest drainage system. They've got a fair amount of advantages that you don't need a lot of skill to use them. They rely on techniques that we're going to have to do anyway. You're going to put a chest tube in. No type and screen. They are rapidly potentially available. They do have some disadvantages because you have to be able to stock them. Can you assure sterility? I submit that's not that big a problem. One of the advantages is it's a ready source in an austere setting. Now, an austere setting does not have to go far. Anybody who likes to go hiking in Jellystone National Park with Yogi Berra will know that do you actually check to see where your trauma centers are or what is the closest receiving hospital? That may or may not actually have blood. You do not have to go to the far reaches of the earth to be in an austere setting and get into trouble. Just an extreme example of this, in the journal Tropical Doctor, which I have to say, surgically speaking, probably has an impact factor of -3, but if you actually look at this, you can actually see that there is opportunity. This is, you can actually do this autotransfusion by MacGyvering it, sterile glass jars, to be able to use this. Is this a case report? Well, lest you think so, they're reporting on 200 patients that they've actually used this technique, where they don't have ready access to blood because it's difficult to actually donate, to bank. It is rife with bloodborne diseases that we've largely managed to eliminate in the U.S., but it's also expensive. You can do this for $4. And I would tell you that this is a potentially life-saving option. So when you actually sit here and ask yourself, overrated? I really don't think so. I don't think you can actually say that this is overrated. Tom talked very nicely about the difficulties of cell saver interoperability, the technology, also the reality of what we have. This also has similar advantages with decreased allogeneic blood transfusion. And it can be used, if you get control of it, to offset some very large hemorrhage, at least to reduce some of the transfusion requirement that you have. Disadvantages: you got to have the equipment, it's expensive, you got to have perfusion, and it potentially has a high cost with that. The big thing that people worry a great deal about, as you saw before, is the contamination. Really, can we use it in trauma if there is enteric contamination? There's a lot of experience with this. There are many papers that have been, series that have been published about this, mostly in cardiac and vascular surgery because it tends to be cleaner, with tremendous experience with this.